facts are that the postcode of the bed that people are born in still pretty much determine how long they live and what they do. And school readiness is a key thing that will change that. It makes it much more likely that young people will leave education with a sense of purpose and clarity and direction, and that actually is a big factor in determining whether or not they are to have a healthier life than otherwise.
So, good evening and welcome to Levelling Up the Conversation, Innovating Healthcare. I'm Angela McFarlane, I'm Vice President, Strategic Planning Northern Europe at IQVIA. And I'm going to be chairing an excellent panel and discussion tonight. For those of you who don't know, IQVIA is a global human data science and clinical research organisation. We delivered the majority of COVID vaccine and treatment trials. And in the UK, we were very proud to be the lead partner delivering the Office for National Statistics COVID infection survey that informed the government our rate, so it's kind of our fault. That survey produced 9 million swabs across 4 million households right across the length and breadth of the UK, including, of course, Liverpool and Greater Manchester. In Liverpool, 28,000 Liverpool households took part in that, with over 380,000 swabs and bloods feeding into the system. And in Manchester, it was 61,000 households that took part, with 795 swabs and bloods. And at the moment, on the clinical research, we've got over 1,000 NHS patients in multiple studies across Manchester and Liverpool in dementia, in cancer, and in paediatric rare disease. So that's just a little bit about us. So on to tonight's event. This is the second in a series of panel events that IQVIA has commissioned with Chamber UK. Chamber UK is a political broadcasting company who are driven to ensure that the government's life science and innovation agenda is pushed out from the Westminster bubble and into the localities where it's actually going to be delivered. So tonight, as we discuss the potential and the promise of innovation to improve the health of local people, we remain acutely aware of the urgent recovery crisis that the NHS, and of course many of you sitting in the audience tonight, are actually having to deliver on. An innovation mindset and culture is going to be absolutely key to helping the NHS recover. And now to the matter in hand and the format for this evening. So we've got a mixture of questions from people in our audience and over 150 people who, like Andy, are attending virtually through the webinar. Thank you all for putting in your questions. Chamber had quite a challenge clumping them into buckets and to themes because there really were so many. But what we've done is we've selected the themes across four key themes, and we'll cover a wide array of topics, and in particular, ones that lots of people requested. I'll read out the questions that were submitted through our online audience and on social media, and I'm going to call on audience members who asked a question to come up to the boom mic here and ask the person in question. We're also going to be asking poll questions throughout the event. So please do help us with this, make the answers significant by joining in the polls. And we're going to be writing this event up as well. There are media here tonight, and the poll results are going to add extra colour and light from you, the audience. So to introduce our panel, we are of course joined, and thank you very much, Andy, to the Right Honourable Andy Burnham, Mayor of Greater Manchester, who many of you will know became the King of the North during the COVID pandemic, for getting the extra funding in place for the people in the Northwest, but also, of course, held a post as Shadow Health Secretary a number of years ago, 2016, I seem to recall. We have Richard Kemp, who's leader of the Liberal Democrat group for Liverpool City Council, and Richard is also Deputy Chair of the Wellbeing group. We have Kate Bratt-Farrar, who's CEO of Heart Research UK. We had Lord James O'Shaughnessy, who's a former Minister for Innovation, the Department of Health and Social Care. Welcome, James. And we have Dr. Ruth Bromley, who is Chair of Manchester Health and Care Commissioning. So, without further ado, let's move to that first poll question. It's going to be repeated at the end, so no pressure to the panellists to impress the audience. And that first poll question And for the studio audience, what I'm going to do is ask you to raise your hand in terms of how much you agree or disagree. The first poll question, which will be repeated at the end, is will the Levelling Up agenda make an impact on health inequalities by the end of this Parliament? So, in the studio audience, we're obviously capturing the webinar audience live, could you hold up your hand? Are you not at all confident that the Levelling Up agenda will make an impact on health equalities by the end of Parliament? Anybody not at all confident? Okay, gosh. You can't put up two hands, by the way. Okay, not very confident. Okay, somewhat confident. We love an optimist. Very confident? Did I even need to ask? Okay, so the ayes have it for not at all confident or not very confident that the Levelling Up agenda is going to make an impact on health inequalities by the end of this Parliament. So the very first question that I'd like to put to the panel, and I'm going to pose this question, Richard and Ruth, is coming in from Hayley Luxton. Hayley is a manager with Prostate Cancer UK, and her question is, what are the biggest barriers to levelling up in healthcare? So, Ruth, would you like to take that question first, and then Richard?
Very happy to,
please.
Thank you. So, when I'm not being a GP or the chair of a commissioning organisation, I'm a clinical ethicist, and one of my academic backgrounds is in rationing of healthcare resources. And my answer to that would be there shouldn't be any barriers at all. The actual pure morality of levelling up is very straightforward, that we move resource to those who need it most to give everybody in society the best opportunity possible. Having said that, as an audience, you've acknowledged some reticence as to whether we're going to get there as a society. And I think some of the barriers do involve ourselves, each as individuals and within our communities and the political and environmental structures we work within, because are we really ready to concede the opportunity and the privilege and the power that some have that others don't? I'm not convinced we are. I think poverty per se, and we're seeing a deepening of some individuals' experience of poverty on a daily basis, particularly in parts of the north where I've been responsible for providing healthcare over recent years and commissioning for healthcare. I think COVID recovery has set us back. We've lost more than 3 years of life expectancy in men in the city of Manchester purely due to COVID. And I cried when I heard that information, because I'd actually set my own benchmark in my mind that we would improve life expectancy for men and women in my city. And our life expectancy is lower than the national average quite considerably. And then I think the final thing really is that at the moment we need to pay attention to the fact that we're at risk of losing the voice of our patients from our systems as we move into an integrated care system. So we have had a statutory responsibility to have the voice of our patients on our boards. And whilst those structures exist to decide what happens to resource, we need to make sure that we're hearing from the people who are impacted by the services that we're responsible for providing.
Thanks for that, Ruth. And we're definitely going to come back to patient voice as we go through. Richard.
I'm afraid I'm going to annoy everyone here now, which is a habit of mine. So, but first of all, welcome to Liverpool as a member of the council here. I don't think that health inequality will ever be solved by the health service. All the practitioners, all the doctors in the world won't alter the fact that there's been health inequality in this city. We know for 175 years, because it's 175 years ago that we appointed the world's first medical officer of health, Dr. Duncan. And we appointed him, I wasn't there at the time, a lot of people think I was, because the rich people worked out that it was the water supply and things like that that would stop them dying from cholera. So they gave themselves an excellent water and sewage supply, and they kept dying. And that's because they then realised that the poor people also needed it, because they were just passing on the problems. So I would invite you to take a bus while you're in Liverpool, the number 75. It starts just at the bus station. It goes through the posh bits of Liverpool 8, where the university is. Then it goes through some of the most poorest communities in the whole of the United Kingdom, and it ends up in my ward, which starts at Liverpool 18, or Penny Lane, as you might know it. And what makes the difference between those two communities is 12 years life expectancy for men and women. And it's nothing to do with health, because if we're ill, you'll give us the same jabs, you'll give us the same treatment. What makes them ill is the fact that in Liverpool 8, you live in far worse housing, you'll have a far worse job, you'll have far worse diet, you'll have a far worse education, and I could go on. Now that's the thing that makes the real difference. And so in answer, if I'd have put my hand up in answer to your first question, I don't think we're going to get this right by the end of the century, because we're talking about inbuilt prejudices, inbuilt problems, but we've got to make a start on them. And I don't believe we're making a start on them. So it's public health, it's the social determinants of health which will deal with the issues, not more vaccinations, jabs and techniques.
Great answer, Richard. Thank you so much. And Ruth, thank you for calling out that 3-year life expectancy in men figure, which is really, really depressing post-COVID. And of course, Richard, your comment about the 12-year life expectancy difference on the number 75 bus. Andy, I hadn't planned to put this question to you, but I kind of felt with some of the things that Ruth said, you'd probably want to come in there. So I don't know if you want to make any comments.
I very much agree with what Richard has just said. And indeed what Ruth said. The pandemic has set us back hugely. But there is something more encouraging that maybe might make people reconsider the poll question, which is that in the years between 2016 and 19, i.e. pre-pandemic, there is some evidence emerging that health devolution in Greater Manchester did make a difference on life expectancy. So the Health Foundation has commissioned a report on health devolution in Greater Manchester. It's been done by the University of Manchester and the University of Melbourne jointly. And it's not published actually, it's still subject to a peer review, but if I could quote the findings, between 2016 and 19, life expectancy in Greater Manchester was 0.196 years higher than expected. And the overall conclusion of the report was Greater Manchester had better population health than expected following devolution. The benefits of devolution were apparent in the most deprived and poorer health areas, suggesting a narrowing of inequality. So there is something encouraging in that. It recognises everything that Richard said about how difficult this is. And I think it's because we've started to develop a whole system approach to these issues. Ruth Bromley was just absolutely instrumental in getting the health service to the table on homelessness in Greater Manchester. And there was a great degree of innovation there, where we got Health Council and other partners together to take a whole system approach to that issue. And that made a difference. But I think more broadly, we've started to look at the social determinants, as Richard said. So we've developed a good employment charter here that we're linking to public procurement. We had a lot of work on early years and school readiness that was beginning to make a difference. So it's not as bleak as the audience might think. I mean, there is evidence that if you devolve properly, you can start to make a difference by bringing the different services together. And there is just a straw in the wind there, if you like, in the Health Foundation report that was commissioned. But I think we've all in a new reality now, aren't we, where things have gone massively backwards in the last 2 years. There's a mountain in front of the NHS now. So how we kind of come back at that situation, but taking heart from the fact that devolution has moved the dial a little bit, that it seems to be where we are right now.
Great. Andy, thanks for that. And if you don't mind, I'd like to go now and invite Vincent Holder, who apparently isn't, I can't see Vincent in the room, from MSD with the next question. And I think it's a really good question, quite a challenging one given the responses to the poll question. But how do we know when we've levelled up? What will be the measure of success? And Andy, I think you've alluded to some of the measures of success in that report that you've just mentioned. But do you want to add anything else to that, please?
Yeah. So life expectancy would be a major measure of that. So at one end of the life course, I would obviously point to that, and we would want to see life expectancy in the northwest of England at the England average, and it isn't at the moment, and certainly not in our less affluent areas. But if you look at it from the other end, you would want to see levels of school readiness as kids go to primary school at the same as the England average, or better, if that could be achieved. Because the work of Professor Sir Michael Marmot has shown that is the biggest thing that predicts a healthier life if kids arrive at school ready to learn. And that is a key indicator for me. That is a measure of levelling up. If we can ensure that kids here are getting to school with all of the developmental progress that is common in the more affluent communities of the South, then I think you are laying the foundations then for a country that is levelled up when it comes to healthy lives. So I would say those two things are absolutely the key thing here. And I think you do have to sort of boil it down to a small number of measures. If you are to say, well, when have we closed the gap? When do we have a sort of an achievement with regard to levelling up when it comes to health? So I would. There are more, obviously. There's many more things that you could point to, but I would say those are two key things. If you get levels of school readiness right in our city region and in Richard's city region, you are making it much more likely that life expectancy will begin to increase across the decades. And at the moment, we are significantly behind on that, but that's where we need to put a lot of our focus. The early years are critical, changing the reality of lives in the northwest. The facts are that the postcode of the bed that people are born in still pretty much determine how long they live and what they do. And school readiness is a key thing that will change that. It makes it much more likely that young people will leave education with a sense of purpose and clarity and direction, and that actually is a big factor in determining whether or not they are to have a healthier life than otherwise. So that's what I would focus on with a levelling up perspective. Really
helpful. And I know you said, compared with the more wealthy areas in the south, but of course you've got very wealthy areas, Knutsford, Hold the Edge, there's much to be learnt locally on the ground and making sure that there's parity there, I'm sure. Richard, is there anything that you would like to add to that?
Well, I think the easiest one to judge, of course, is life expectancy. But I think we have to accept that it's a fairly crude measure. What's the life expectancy for people from different ethnic groups, for example? Are we meeting particular problems? But it's not only how long you live that's important, but I think it's the quality of life you have. So let's take the example of an 11-year-old, and I'm not saying we shouldn't be doing things with preschools as well. I support Andy on that. But we know that 3% of our 11-year-olds are clinically obese. We know that that's going to lead them to at least 2 major interventions by the health service by the time they're 65, and they won't live much longer than that. We know that a lot of their life is going to be miserable because they will have mental and health problems which result from that. I went into a house the other day. It was actually in Tiverton, I won't tell you what I was doing down there, which had 12 big oxygen cylinders, and the man was 45 years old and huge. So I think we've got to find a way of measuring the quality of life, because everyone's in ill health comes for different reasons. So yes, we've got to work at the macro level, but we've also got to work at the micro level at the same time.
So if I could take it now, a question from one of our people joining via the webinar, Chris Smith, who is Chief Operating Officer at the National Institute for Healthcare Research. We also have Professor Martin Gibson in the audience today, who's very close to that organisation. I think it's really helpful. But Chris is asking, how can clinical research support the levelling up agenda? And Kate, I'd like you to come in on that one first, and then to James, please.
Sure, I think, I'm sure you'll have your own opinions, but I'd probably break it into two. So I think there is how research as a sector, so health, medical and pure science research can contribute. And there's already stuff around where that research takes place and moving it from the south and making sure there's a better spread. But also who's doing that research? How are we supporting early career researchers across the country? And I think that's more general. It's not just about health. I think in terms of how research can support this agenda in terms of healthier lives, longer lives, we need to do, some of the stuff we fund is, even I don't understand it, is how do we make a test faster? Which will be great, that's a really good thing. It means that we can test more people more quickly, more cheaply. But I think there's also something about why aren't people accessing the things that are available? So for example, cardiac rehabilitation is there, people are offered it, but why aren't people taking up that rehab? Now I would, so how are we getting to the people that aren't uptaking that? And I think that's really, really important. It's about getting into communities and researching with people about what the impact is on their lives, and that will ultimately make a difference. So can I add,
and I'm sure Martin would come in and back me up with some stats that I can't quite pull out the back of my head at the moment. Primary care research, research that is actually, when a doctor's saying to a patient, I want to put you on this drug for your diabetes, perhaps they could also be saying, and I'm aware of this clinical trial that's going on, would you like to take part in that? So research becomes part of the practice. I mean, at the moment, from a commercial clinical research perspective, only 1% of all commercial clinical research is carried out in primary care. And yet here we are running massive programs on dementia, on diabetes. And the challenge with rare disease patients is that they're going around on this diagnostic odyssey, and they're in primary care. And if only we could, have that conversation with them in primary care, I'm sure that would go a long way towards that. James, can I hand over to you?
Yeah, just a couple of points. The first one is to sort of almost reframe this as an opportunity, which is where there are poor health outcomes. That means there is lots of data on disease, and data on disease is interesting to people who carry out research. And so, sort of almost conversely, areas which have poor healthy, I would say healthy life expectancy is the right measure rather than life expectancy, as Richard was pointing out. Those are actually ought to be sites of more research. So the question then comes, how do you incentivize and make accountable the organizations in those areas, where they're health or non-health organizations, for actually getting involved in research, and to make sure that there is a proper incentivization and a redirection of resources into those kind of areas for the specific measurable goal of better healthy life expectancy, which of course means treating chronic diseases and other diseases. And then the final point I would make is, don't think of clinical research as something that happens in universities or with sort of clinical academics. It's just a sort of, within the academy or within the NHS. This is a wealth generating opportunity. And of course, if you generate wealth, you generate economic activity, you get the better jobs that Richard was talking about, and probably nothing does more for better health than high standards of employment and high good quality skilled jobs. So it's about, I think to some degree, about reframing how we think as clinical research, not as something that is sort of added on to treating a problem, but actually as a sort of wealth generator in the areas that actually are going to be the most interesting places to do it.
Great, thank you for that. So before we go on to our patient voice questions, what I'd like to ask you now is another poll question. I'm hoping it's going to be slightly more optimistic than the last one. What is more important for the future success of the NHS? Recruiting more staff or making better use of technology and innovation? So again, I'm going to ask you to raise your hands. So if it's recruiting more staff, can you raise your hand that is going to make the most difference? Interesting, didn't expect that. So quite clearly then, we have the show of hands for making better use of technology and innovation. Yeah. And we've just this afternoon, and any of you who are part of ICSs or AHSNs or in the wider local authority systems had a forum looking at innovation and integration in ICSs, and we're looking for more people to join this forum. So if you want to know more about that, we'll be able to give you some details at the end. So, Ruth, Bromley, you asked this killer question, and we're directing it to you, Andy. And that question is, how do we address tensions that exist between hierarchies and structures in the health system? So, Andy, you can go first, and then James, I'm going to bring you in from the National.
I'm sorry, Andy, it was in private. I didn't realise it was going to get asked.
Well, I used to deal with those tensions for a living, and James did as well. And you do get a clear kind of frustration, actually, from being a health minister, just how sometimes that stuff holds the health service back. The different professional disciplines rubbing up against each other, the sort of hospital community divide, the mental health, physical health divide, and health and social care. You know, this is and it has been a health service that's been very hierarchical at times, sometimes quite divided. And if I'm going to put my hands up, I had qualms about some of the policies of my own government, in that it kind of drove a sort of certainly an institutional fragmentation, where the focus was on institutions, perhaps less on systems. And I think if there's something that gives me hope coming out of the pandemic, it's the extent to which, here anyway, GM has moved towards becoming more of a health system as opposed to a collection of slightly competitive institutions. I did witness in the middle of the pandemic greater collaboration between health and social care at a very practical level that probably we'd never seen before, when we had hospitals sharing PPE with our social care providers. And I am hopeful that some of that now will remain in the new ICS system, where it does have the mentality of working as a health and well-being system, as opposed to factional professions, or people who are loyal to a part of the system but not the whole of the system, or loyal to an institution more than they are to the health and well-being of all of the residents of Greater Manchester. So I actually have some hope for the ICS reform. Ruth raises a really valid question about patient voice, or even citizen voice, if I could put it that way, at the heart of the system. And that in many ways is the way to get over those professional divides. Everyone's first loyalty is to the resident, the citizen, or to the patient, isn't it? And not to the employer or the professional college, the Royal College, or even a part of the system. And that's something we really need to work hard to instill at the heart of the ICS reform. I am hopeful that we've got more opportunity at the moment to kind of build that spirit than we've possibly had in recent times, and I include the time when I was in government. But time will tell.
Thank you, Andy. James, do you want to add anything to that?
Yeah, just quickly. I think, referring back to that conversation about health inequalities, they are so large in scale, and the range of them is so great. It follows from that it can only be by empowering local leaders to operate not just on health, but on all of the things that determine what health outcomes are, that they actually have control. So I'm completely convinced of the need for devolution from the centre. It's why the reasons, like Andy, I hope the new ICS structure will work, albeit I think there are some new tensions coming in there between sort of provider collaboratives, for example, and ICSs. I played my own very small part in this when I was the minister, because we took the decision to devolve public health powers from the centre of government actually to Greater Manchester, which, as Andy's explained, he's been using, and his team with Ruth and others, very wisely and with impact. But that needs to happen everywhere. Just finally, to that point that Andy made, ultimately this is about the patient and the citizen, and we need to give them more control and agency over their care so they are not done to. I think the digital revolution actually produces potentially a massive opportunity there, but it is obviously spread unevenly. And making sure that is addressed is going to be really important too.
Thank you. So let's come now to some of the patient voice questions. I'm actually going to take the liberty of combining two questions into one. So Gemma Peacock, who's Patient Experience Advisor at South Tees Hospital's NHS Foundation Trust. She asked, how can we capture patient and carer feedback in an innovative way? And then I'd like to add on to that Mark Duman, who is Chief Patient Officer at MD Healthcare. And I know Mark has been at this a long time. How are patients included in the levelling up conversation? So I want to direct those two questions both to Kate and to Ruth, if I may. Pithy answers.
Quickly, so in terms of being included in the levelling up conversation, do they want to be? Do they care what a levelling up conversation is? I'm not sure that's the conversation we want to be having with individuals and communities. In terms of being innovative, I don't think it's necessarily about being innovative. It's more about being representative. And any of us who've been around for more than 3 years, because that's generally the cycle, know that we do this and we reinvent the wheel over and over again. And what we still end up with, no disrespect, is professional patient groups. So how do we, just like with our research, how do we reach people? Why would they want to talk to us? Why do they want to feedback? What do they think the impact is going to be, and what is the difference going to be for them? And I'd link that specifically to people, particularly carers, who feel like they are battling a system, not necessarily because healthcare professionals aren't doing the right thing, but because if you have a chronically ill child, you will fight for every little thing you need. So it can feel like an adversarial relationship. So how do we get an honest conversation with those people? And the other thing I'd say is, in the interim, while we work that out, I'm only 43, I'm sure I'll work it out before I retire, we could trust healthcare professionals when they say, my patient said this. I think that's absolutely fine. We tend to have a thing of distrust. So if GPs are saying, my patients are coming and saying this, this and this, that can't possibly be true, they must have their own agenda. I'm not sure that's right. Let's listen to everyone in the room, including patients and carers, somehow. Don't have an answer.
And to your point, not necessarily the professional patient groups, listening through the GPs, through the consultants as well, through the nurses.
Yeah, exactly.
But then how can we use innovation to capture that as well? And obviously the primary care networks should be a real voice for that. And I think you mentioned earlier on that there's a statutory responsibility to have patient voice on the ICBs, but then are they going to be, the professional people that will pop up everywhere? Do they represent difficult to reach communities? So Ruth, your thoughts on this, please.
Yes,
maybe even your GP hat on.
Well, my point earlier was that there is no statutory responsibility of IC boards, whereas there has been of CCGs. So we need to be careful that we don't lose something really pivotal. So the innovation for me is that we have already heard, but we haven't necessarily listened or responded. So what we hear, and Andy and I have worked a lot in co-production, particularly with people with lived experience of homelessness, actually people are sick of being asked what they want. They want someone to do something about what they've already told the system multiple times already. So we need to step up and actually give the power away and do the things that people are asking for. And some of that is about trust. And I had written down partnership with frontline workforce, but some really innovative ways. So I was on a call this morning with Lord Alan Howarth of Newport, and he's part of the National Centre for Creative Health, as am I. Well, let's use stories. Everyone's got a story about their own health. I have my own, unfortunately, in recent months, So some of us are patients and representatives within the system. We sat on a Poverty Truth Commission for 3 years. I was a co-sponsor with my colleague Bev Craig from Manchester City Council, and we worked with grassroots commissioners, and their tagline was nothing about us without us. And yet a lot of the startup conversations in the new world have still started behind closed doors with professionals, without anyone in the room who we're talking about. So they're very simple and easy things to change. We have group consultations that are, have been tried and tested now. So let's take those forward with us and the learning that we have, and let's empower those voices. I'm not overly keen on the word empower. I'm struggling to think of the best one. Maybe the audience can help me. In terms of how are patients included, I think there's a question about how they should be included. And I do think there's a distinction between citizen and patient, and I do think we need to be careful. So I've been talking about cherry pie in Manchester. Don't ask me why, but health is a fifth of that. And if you collapse now, you will be very grateful for that blue light response and the care that you get in A&E versus all of the attention we do need to pay from the other 4/5 around wider determinants. So I think both of those things matter. And if you've had your life saved, then you're going to be really, really grateful for pure health intervention, actually. So we do need to understand the difference between asking a citizen and asking a patient who has lived experience of a particular condition along with their carers and their families and their loved ones. And we need to value and respect that information that we get back once we ask people. I think there's infinite potential. My ask would be that every single board structure in the land puts at least one patient representative voice on their board, and that they give them parity, and that our governance structures evolve to insist upon responding to the voice from patients and citizens. And I know that might be a step too far for some people as they start the first steps, but otherwise, I think particularly for us in Greater Manchester, we stand to lose a great deal of what we have gained over the last few years, actually.
Thank you for that. I mean, I think what I was loving with those answers was some really positive suggestions to, clearly a very difficult question. I'm going to run the next poll question now. I'm acutely aware, Andy, that you're on a timeline, but if we can very quickly just ask, on a scale of 0 to 10, how confident are you that integrated care systems will be innovators in transforming local population health? So, 0 to 10. How can I do that with? Who wrote this? Hands, please.
Got 10 fingers.
Yeah, 10 fingers. So, how confident are you? So, put your hands up if you're very confident. I'm going to do it in reverse order this year. That integrated care systems can be innovators in transforming local population health. And just listening some of the things that Andy said about, the achievements of devolved Greater Manchester. So, if you're very confident, hands up. Good, we've got some optimism in the room. If you're quite confident, great. I'm not even going to the depression end. I'm going to finish on a high. So, Adrian Jonas, hello, Adrian. So, didn't recognise you in person. So, Adrian's got a question which I would like, if possible, Andy, to put to you and to James. So, over to you, Adrian.
Hi, Andy. Adrian Jonas, Chief Analyst for the North West region in NHS England. And my question's basically, so we've got, Angela just touched on grassroots innovation. How can that be adopted at scale and pace? But crucially, how can we ensure those innovations are adopted at scale and pace based on robust, objective, systematic evaluations, not simply who is shouting loudest?
So, Andy first and then James.
Well, one answer would be to have NICE's writ running a bit larger than it has done in recent years again. NICE was brought in for a very good reason in 1997, and I think it was a very successful innovation. And I still think there is a need to have that real clarity with the evidence base that underpins what we're asking people to do. And I noticed that Jeremy Hunt in his book has recently spoken about the Cancer Drugs Fund, which we kind of said would undermine NICE, and was starting to sort of do things outside of NICE. And I think he almost admits that in the book. And I certainly feel there's a role for a central body at the national level. And NICE, I think, has proven that approach works. But then looking more locally in terms of not sort of what's given to people in terms of the intervention, but how you do it and how you organise services. I think ICSs could play a big role here. Certainly Sir Richard Lees, who's coming in as the chair of the Greater Manchester Integrated Care Board, has said his first observation is just how patchy we still are. So we like to pat ourselves on the back, but sometimes we're not as good as we might think we are. And I think there is a big opportunity here to start to more systematically spread best practice around the Greater Manchester system. And the ICS is a good vehicle for that, isn't it? Because if we're moving away from the institutional focus and the competition between institutions, as we should do, then I think we might be able to create local mechanisms for the uptake of good practice across the system. Just one last point, if I could, Angela, on innovation, and it touches on the last conversation between Ruth and Kate. I think we're going to bake innovation into our system if we, at this point, cement a new and more significant role for the voluntary and community sector within the health system as permanent partners, long-term partners, rather than the approach where they're often on the fringes with a bit of project funding here and there, which doesn't work. I think if we bring in voluntary and community sector, actually we're going to need to provide alternatives to people who are waiting to access acute services or elective services. We're going to have to be better, I think, now at giving people support while they're waiting to access the system. I think the voluntary and community sector can innovate hugely in that area, but also bring citizen voice, community voice, patient voice into the room. And I think this is a moment not just to sort of get rid of that hierarchy within the health service or between the health service and local government, but also bring in communities in the form of the voluntary and community sector and have their voice very much in the room. And I would really recommend that all ICSs do that.
Great, thank you. Can I bring in James, please?
Yeah, so look, two blunt truths and one solution among what I hope will be many. First blunt truth, we are brilliant at creativity in this country and we are very poor at scaling. By the way, that's not just true of health, that's true across our economy. The second is, in a health context, you won't get scaling of innovation. This is the point that Andy was making about NICE, unless you have reimbursement. We have it for drugs, we don't have it for other things. And you cannot expect one part of the system to behave like the other when there is that fundamental difference. Other than fixing the obvious thing about reimbursement, which is not free, one thing that we were talking about in the forum that Angela just mentioned is actually creating accountability at local level, or even just transparency about the amount of R&D, innovation activity and time that clinicians are allowed to do as part of their daily practice. Just shining a light on that so that actually we create the opportunity for them to contribute, which everyone wants to do, but no one has the time, could be one cost-free way of starting to actually improve and make accountable that really important activity.
Great answer. Thank you for that. And Andy, thank you for your comments with regard to NICE's remit. And I certainly think their 5-year strategy, working as they are going to be doing with the Accelerated Access Collaborative and more closely with the MHRA, should go some way. I do want to flag, we're about to publish a white paper and it asks the exam question, can ICSs be a catalyst for the uptake of NICE technologies going forward? We've got a series of recommendations, but most importantly, for the people in this room, we've used our prescription data and we've linked it to deprivation index to show that on average it takes 4 years for local systems to implement a NICE technology. And don't forget, you've got 2 years for the technology to get through the NICE system in the first place, or perhaps 18 months. And I can tell you, I'm sorry to say that Manchester and Liverpool, when we match it to the deprivation index, it's not looking very pretty, but we'll be very happy to share that stuff with you in the next month or so. So, William Pope, would you like to raise your question? And I'm going to take that to James. Andy, how are you for time?
I'd have to leave at 25 past, I'm afraid.
Okay, cool, great. So I'd like you to take this question along with James again and Richard too. So, Will, over to you.
Thanks, Angela, and thank you, panel, for a great contribution so far. And Richard, thanks for the welcome back to Liverpool, in my case, where I went to school. So it's great to be back.
You've lost the accent, though.
It was beaten out of me, Richard. So I'd like to build on, actually, Richard, right at the very beginning, touched on this issue, and then you've all, Andy, James, Ruth, you've all touched on it to some degree. But by the way, I'm chair of one of the academic health science networks and the national network, and I'm chair of the Suffolk and North East Essex ICB. And so I see both sides of this debate that you've been having. And my question is, do you think that we're investing enough in the wider innovation agenda to make a significant impact on the wider determinants of health?
Okay, thanks, Will. Right, I'm starting to get signals from the back on time. So, pithy answer? Andy? Pithy answer?
No, definitely not. We are trying, though, as a city region. We have a body called Health Innovation Manchester, which is something we've set up ourselves. We're pleased that the government has talked about an accelerator with regard to R&D spend and getting areas outside of the Golden Triangle a share of the pie. But no is the answer. I think we need to do much, much more.
Richard, Hithy.
What came out of the COVID situation was huge innovation, firstly in terms of production of vaccines, which is very important at that level, but also new ways of working between the health service and others. I wrote to the Chief Constable today on behalf of the Council talking about how the police get involved in health, with the PCNs, with the fire service, with the community, etc. Doing things that we do at Health and Wellbeing Board level, neighbourhood by neighbourhood, community by community. What's important if you innovate is you don't lose it, and I'm very much afraid we're going to lose some of the good stuff that came out of the pandemic because we didn't record it, and now we're going back into old ways.
James, you want to add anything?
Well, just very quickly, in the spending review, actually, for this sort of next 3 years, there's going to be an increase in health R&D funding from the centre of government. But my question is, how much of that is actually controlled locally to deliver on local objectives? And I suspect even more of it than ever is being centrally controlled, and that's a problem.
Okay. We're going to come to our final question, but we might not. Is Darryl Clough in the audience tonight? No. So I am going to again take Chair's prerogative. He's not here, so he can't ask his question, and we haven't actually got time to cover his question. But what I would like to do now is go to the first poll question that we asked you earlier on. So will the Levelling Up agenda make an impact on health inequalities by the end of this Parliament? You were pretty negative, I think it would be reasonable to say, about that before. Does anybody raise your hands if you think that, actually having heard from our panellists tonight, you feel a little bit more optimistic? So if you feel more optimistic, raise your hand. Yeah, we're ending on a depressing note. But that does not reflect, of course, at all on our wonderful panellists tonight. I mean, it has been, I hope you'll agree, quite wide-ranging. I think I liked it because there were an awful lot of solutions. You know, I particularly picked up on Ruth's ask, you know, to make sure that ICBs, you know, have a patient and carer voice, citizen voice, you know, on their boards, and that they are actually listening to them. And then some great recommendations from the wider panel. So with that in mind, I have got one other question that I've got to ask. Ben's signalling at me. On your chairs, we've put some examples of what IQVIA is doing to help ICS systems with recovery. So, for example, the kind of pharmacists that we have that can go in and work in primary care networks to assess patients with the long-term conditions that we talked about. So the question is, and you don't have to raise your hands because that would be embarrassing for me if you say no, but to those that are actually on the virtual, would you like to hear more from IQVIA about some of the solutions that we have to support ICS systems, either with research or with the recovery agenda, and that includes AI and stratifying waiting lists. So that will go on. I think without further ado, because I don't want that white wine to go warm, I am going to bring this panel to an end. I'd like the audience to thank the panel in the traditional way, and thank you all for coming, for great questions, and I hope you found it a really good use of I think it's Tuesday today, of a Tuesday evening. Thank you so much. And Andy, please feel free. You're only 6:25, so thank you so much for being in two places at once. Really appreciated.
No problem at all. Sorry I couldn't be with you all. No, a great discussion. Thanks for letting me be part of it. Bye all.